Welcome to Module 5, Respiratory Diseases, Neuromuscular and Neurological Diseases in Patients with Disabilities. I will only narrate a few of these slides, and the Navatar will take over. Intermittently, I will return on slides that do not have her voice. There are several lower respiratory diseases that we need to be aware of in clinical practice: asthma, pneumonia, chronic bronchitis, and others as COPD, tuberculosis, cystic fibrosis, and pulmonary fibrosis. Asthma is a chronic inflammatory disease which increases responsiveness of bronchial airways. The classifications of the severity can be mild, moderate, or severe, and the etiology can either be environmental, chemical, respiratory infections, pollutants, exercise, cold air, or stress. Clinical manifestations involve wheezing, coughing, nasal flaring, dyspnea, chest pressure. Xerostomia and unpleasant aftertaste often are common with inhalants, which we need to be aware of with our patients when we find out that the low amount of saliva has affected their gingival tissue and possible decay. Toxic blood levels also are evident, and they will be found with different types of antibiotics like erythromycins and Cipro. We must avoid aspirins, any non-steroidal anti-inflammatory medications, barbiturates, and narcotics when these patients are on their medications. Also, as clinical practitioners, we must avoid any airbrush polishers or ultrasonic scalers due to the aerosol effects. One benefit with local anesthesia is that the epinephrine that is used in the medication and local anesthetics is not a contraindicated medication for asthma patients. Actually, it does help them in situations of treatment to help from developing an attack in the dental chair. There's just a couple of things you want to remember when you're dealing with asthma patients, and that is to remind them to rinse their mouth after they use their inhalants. This will reduce the incidences of caries. Also, we want to recommend xylitol products to reduce decay and increase saliva flow. Chronic obstructive pulmonary disorder, also known as COPD, is an irreversible obstruction of airflow that causes dyspnea. This condition is considered to be preventable and treatable, but can be severe and debilitating to some patients. It is worsened by tobacco use, which is known to be a major cause of the disease. Bronchitis and the combination of emphysema coexist with COPD. Clinical considerations include seating the patient in a semi-supine position or upright. Having oxygen readily available is a must. Be aware that the medications may affect salivary flow and lead to xerostomia, and perform oral exams and inspect for lesions related to tobacco use. Avoid the use of a rubber dam, as this may cause difficulty in breathing. Air polishing may precipitate an attack, as well as ultrasonic scalers are known to promote bacterial aspiration. The last of our respiratory diseases is tuberculosis. This disease is communicable and airborne and affects the lungs and other organs. It's caused by the Mycobacterium tuberculosis. In at-risk patients as HIV, alcoholics, drug abusers, individuals sharing habitual settings, healthcare workers and immigrants, and medically underserved are the ones that are most prone or at risk. Symptoms involve usually a mild to low-grade fever, occasional cough, loss of appetite and weight, listlessness. Typical implications for dental care would involve the risk of transmission, which we will always use universal infection control, recognizing the symptoms and minimizing any type of aerosol equipment patients that are recovering from the disease. I'm going to take a step back on the neuromuscular and neurological diseases and let the avatar take over. I don't know that she does any better than I do in pronouncing things, but she certainly is a little interesting to listen to. Enjoy the rest of the lesson.
Parkinson's disease is a chronic progressive disorder of the motor system. The loss of dopamine synthesizing neurons affect muscle activity, causing rigidity, tremors, expressionless face and voice interferences. Common onset is at middle to old age and is accompanied by depression and dementia. Treatment is dopamine replacement medications. Oral findings include masked face, lax expression and movement, tremors of tongue, lips and neck. tongue thrusting, lip pursing, impaired swallowing and drooling in later stages, xerostomia from medications, and burning tongue syndrome. 4 main types exist. 1. Spastic, which is associated with rigid muscles and jerky erratic movements. 2. Athetoid is defined as slow riding movements. 3. Ataxicus involves altered balance and control, and 4. Hypotonic, which involve weak, floppy muscles.
By the extrapyramidal system, which includes the substantia nigra, subthalamic nucleus, basal ganglia, and thalamus. The extrapyramidal system can either promote or inhibit movement. Let's take a closer look at the key extrapyramidal structures involved in Parkinson's disease. The basal ganglia are 2 large groups of nerve cells located near the base of the brain, which consist of the caudate, putamen, and globus pallidus. Together, the caudate and putamen form the corpus striatum, or striatum. The substantia nigra is a tiny structure located deep within the brain. There are actually 2 structures, but they are typically referred to as a single entity in the medical literature. Normal movement depends on adequate levels of the neurotransmitter dopamine, produced by cells in the darkly pigmented zona compacta of the substantia nigra, and delivered to the striatum and other parts of the brain. Because this motor pathway involves the substantia nigra and the striatum, it is known as the nigrostriatal pathway. The synthesis of dopamine begins with the amino acid tyrosine. Within the neurons of the substantia nigra, tyrosine is converted into levodopa through the action of the enzyme tyrosine hydroxylase. Levodopa is converted into dopamine through the action of the enzyme dopa decarboxylase. When signaled by an impulse traveling down the axon to the synapse, dopamine is released into the synaptic cleft. Some of the released dopamine binds to dopamine receptors on the receiving neuron, triggering a signal that is relayed through neurons to the motor center in the cerebral cortex of the brain. This signal eventually travels through the spinal cord to modify activity in muscle cells. Free-floating dopamine in the synaptic gap may be taken back into the neuron that released it and stored for future use in a process called reuptake. It may also be converted into other substances through the action of the enzymes monoamine oxidase B, or MAOB, and catechol-O-methyltransferase, or COMT. Within the striatum, there is a delicate balance between dopamine and acetylcholine, another important neurotransmitter. In patients with Parkinson's disease, there is massive degeneration of dopamine-producing cells in the substantia nigra. The dopamine supply to the striatum is gradually reduced. This disrupts the balance between dopamine and acetylcholine, resulting in a relative excess of acetylcholine. When 60% to 80% of dopamine-producing cells in the substantia nigra are damaged, the extrapyramidal system loses the ability to effectively promote movement, and the motor symptoms of Parkinson's disease, such as resting tremor, rigidity, bradykinesia, and postural instability, begin to appear. Therefore, a primary objective of pharmacologic therapy of Parkinson's disease is to increase dopamine levels in the brain.
Cerebral palsy is diagnosed by detailed clinical problems in such a way that the diagnosis eliminates possible diseases. 3 classifications exist: the hemiplegic, diplegic, and quadriplegic. Medications reduce convulsions and muscle stiffness associated with the disease. Causes of cerebral palsy include injury to the brain during forceps delivery, lack of oxygen to the brain, and infections contracted during delivery. Signs and symptoms of the condition is dependent on severity. 20% of cases are mild, 50% of cases are moderate, requiring help due to impairment, and 30% of the cases are severe with total incapacitation. Psychotherapy involves massage, exercise, hydrotherapy, and special training for walking, swallowing, and talking. There are a few upcoming videos. This particular one is a voice-led PowerPoint presentation that would detail the specifics of cerebral palsy.
Cerebral palsy. Cerebral palsy is a progressive neuromuscular disorder causing mild to severe disabilities throughout life. The condition is manifested as a group of persisting qualitative motor disorders which appear in young children due to damage to the brain during delivery or due to some pathological conditions in the intrauterine life. The neurological problems are multiple but non-progressive in nature. Approximately 2 per 100 live births result in a child with cerebral palsy. Cerebral palsy is not hereditary. The causes of cerebral palsy include injury to the brain during delivery, as a complication of forceps delivery, lack of oxygen supply to the baby during delivery, and infections during delivery. Signs and symptoms of cerebral palsy include the signs and symptoms may not be similar in all babies affected, depending upon the damage to the brain, where there may be mild to severe lesions. Mild cases. 20% of children with cerebral palsy will have a mild disability. Moderate cases. 50% of children will have moderate disability. The affected children will require self-help for assisting their impaired ambulation capacity. In severe cases, which accounts for about 30% of the children with cerebral palsy, they are totally incapacitated and bedridden, and they will always need help and care from others. Abnormal findings in cerebral palsy. Children with cerebral palsy will have abnormal neonatal reflexes, stiffness of all muscles with awkward motion, extension of extremities on vertical suspension of the infant. There will be a scissoring of the lower limbs due to spasm of the abductor muscles of the thigh. And in severe cases, the back will bend backwards like in an arch. Children may have total or partial paralysis. They may have arrest of neurological and behavioral development. Swallowing may be difficult in some cases. There will be a drooling of saliva and mild to severe mental retardation. Abnormal movements are seen in some cases, tremors with typical movements. If the cerebellum is affected, there will be a loss of muscle tone with difficulty in walking, complete or partial loss of hearing. Speech may be affected, and there may be a squint, and other visual problems may be associated. Also, convulsions may be seen in some children. Cerebral palsy is diagnosed by detailed clinical examination and by eliminating other similar diseases like a brain tumor or progressive atrophy. All investigations like a CT scan, MRI, and routine investigations are needed to rule out other diseases. Management of cerebral palsy. General management. This includes proper nutrition and personal care. Symptomatic medicines are needed to reduce convulsions and muscle stiffness. Diazepam can be used to reduce spastic muscles, and dantrolene sodium helps to relax skeletal muscles. Physiotherapy. Here, massage, exercise, hydrotherapy are utilized to help with some of the symptoms of cerebral palsy. Special training is given to teach walking, swallowing, and talking, and the affected children are also trained to hold articles for routine activities. For rehabilitation, moral and social support should be given to these children. The children affected with cerebral palsy should be sent to special schools where special training can be given by trained staff. Depending on the disability, special instruments and machines are given for locomotion and to assist in day-to-day activities. Occupational therapy. This is given by occupational therapists. Some of the training will include job training so that individuals with cerebral palsy will be able to obtain suitable work when they are adults. I'd like to thank you so much for watching. Please don't forget to subscribe to get new informative videos.
Let's take a moment to view this video on peripheral neuropathies. We will follow this video with information regarding facial neuropathy.
If you're watching this video, you may be looking for a treatment for peripheral or diabetic neuropathy. Have you been diagnosed with neuropathy? Do you know someone who has the condition? The great news for all those whose lives have been touched by neuropathy is a diagnosis doesn't have to be the end of the world. Let's take a brief look at what neuropathy is. Neuropathy is a functional disturbance or pathological change in the peripheral nervous system. So what are the symptoms? Well, pins and needles, a sensation of burning in the feet, leg, hands and arms, muscle weakness, coordination problems, foot ulcers and skin infections are just a few of the many symptoms that you may suffer from. So how can we cure or at least ease the symptoms that you have? Well, light exercise and being active is extremely important. Diet is crucial. Healthy eating by avoiding fat food high in sugar, junk food and soda. Taking a balanced intake of omega-3 and omega-6 fatty acids. It goes without saying that alcohol and tobacco should be eliminated. Alongside this, there are now neuropathy treatments that are relatively available to help you. If you visit neuropathytreatment.com, you'll find a treatment which gives a balance of 5 wonder herbs to help reduce and reverse your neuropathy.
One very popular facial neuropathy is Bell's palsy. It is an abrupt function of impairment which resembles a stroke. Symptoms include pain behind the ears, drooling, altered taste, tearing, paralysis affecting one side of the face. It can also be followed by a viral or respiratory infection, and recovery without intervention is possible. Oral findings involve cheek biting, xerostomia, glossitis, and candidiasis. Trigeminal neuralgia, which involves the cranial nerve, fifth cranial nerve, which is affected, resulting in a severe pain from compressing arteries, benign tumors, or vascular malformation, is also in this category. Females are more common to attract trigeminal neuralgia over the age of 50, located on the right side of the face. Symptoms are the onset is sudden, severe pain is unilateral, molar division in jaw and tongue are involved, with no significant oral findings. Let's take a moment to view this video on Bell's palsy.
Palsy is a paralysis of one side of the face. It affects approximately 40,000 Americans every year. This patient education lesson will review some of the anatomy of the facial nerve and will explain the disease and what should be expected. Anatomy. Most of the muscles of the face are controlled by the facial nerve, also called the seventh nerve. The seventh nerve extends from the brainstem to a very narrow canal in the skull. It then exits the skull just behind the ear. From behind the ear, the seventh nerve fans out to provide the muscles of the face. It allows the forehead to move, the eyelids to close shut, and the mouth to close and smile. The seventh nerve also supplies a small muscle in the ear. That muscle is responsible for muffling the sounds we hear. The facial nerve also controls salivation, which produces spit in the mouth, and lacrimation or crying. The facial nerve is also responsible for taste sensations in the tongue. Symptoms. Bell's palsy is named after Dr. Charles Bell, a Scottish doctor who first described the condition in 1882. Palsy is the medical term for paralysis or being paralyzed. In patients with Bell's palsy, the facial nerve suddenly quits working. The weakness reaches its worst point within 48 hours. The most impressive finding of this disease is the paralysis of the facial muscles. With the facial muscles paralyzed, the eye is not able to close and the mouth droops. The malformation of the face with Bell's palsy is usually very unusual and disfiguring. The good news is that Bell's palsy usually improves on its own in a matter of weeks to months. The seventh nerve usually heals itself completely. Along with paralysis, Bell's palsy patients may experience sounds being louder than usual and some pain in the ear area. Patients with Bell's palsy may experience loss of taste sensations on the affected side of the mouth. Lack of taste is sometimes not even noticed, since the other side of the tongue's taste sensation still works. Causes. The cause of Bell's palsy is thought to be a viral infection of the seventh nerve. Inflammation due to the infection causes the nerve to swell. The nerve may cut itself off in the thin bony tunnel on its way to the face.
The following video will introduce trigeminal neuralgia.
Trigeminal neuralgia is a condition that affects about 40,000 patients in the U.S. every year. Its treatment mostly involves the usage of oral medications. If medications are not successful in controlling the pain, surgery may be indicated. This patient education module will help you understand better this disease, the benefits and the risks of the various surgical treatments. Anatomy. The trigeminal nerve is the nerve responsible for most of the sensation in the face. There is a nerve on the right side and another one on the left side. The main part of the nerve, or ganglion, is located at the base of the brain, deep inside the brain. From there, it divides into 3 branches. The first division, known as V1, provides sensation to the eye, upper eyelid, and forehead. The second division, known as V2, provides sensation to the cheek, lower eyelid, nostril, and upper lip and gum. The third division, known as V3, provides sensation to the area of the jaw, the lower lip, and gum. V3 also controls some of the muscles responsible for chewing. Symptoms and their causes. Trigeminal neuralgia is characterized by severe pain in the face. The pain lasts for a few seconds and can spread to the rest of the face. However, it is usually limited to one division of the trigeminal nerve. Between bouts of severe pain, the patient is usually pain-free. Specific sites in the patient's face, such as the corner of the mouth, gum, or lip, can act as a trigger point. The pain can be set off when one of these sites is touched. The pain can be so severe that the patient may refrain from eating or speaking for fear of eliciting the pain. It is still not clear what causes this pain. Trigeminal neuralgia is most often thought to be caused by abnormal compression of the ganglion of the trigeminal nerve by a normal blood vessel that has become more rigid because of advanced age. Other reasons for trigeminal neuralgia include tumors, multiple sclerosis, and abnormal blood vessels. However, these are very rare.
Spinal cord injury, known as myelopathy, occur from trauma or disease. Classifications are dependent on the severity of the condition. Quadriplegia is the loss of function of the arms and legs. Paraplegia is the loss of function of the trunk and legs. Medication for the condition include NSAIDs, muscle relaxants, antidepressants, narcotics, and anti-seizure drugs. Secondary conditions occur and include autonomic dysreflexia, known as AD, which is the overaction of the autonomic nervous system. This condition is life-threatening as it causes dysfunctions that affect breathing, blood pressure, and heart rate. Respiratory infections, spasticity, depression, and cutaneous pressure sores are common conditions seen with spinal cord injuries. Chronic pain management is usually involved in daily care of these patients. Specialized home care will be required to help patients adapt oral hygiene care to fit their needs. 50% of epilepsy cases are temporal lobe. There are currently over 20 anticonvulsants medications available to treat the condition. These medications have many side effects that include fatigue, abdominal pain, blurred vision, rashes, inflammation of pancreas or liver, low white blood count and platelet levels. There are no known oral side effects. However, damage occurs during seizures as scarring of lips, tongue and oral mucosa, and teeth fractures. Clinical contraindications include oxygen and nitrous as they elicit seizures. Morning appointments are recommended to reduce fatigue.
Seizures in epilepsy can be defined by a less than 2-minute cerebral dysfunction. There are 3 types of seizures: tonic-clonic, absence, and general. They have many causes. The following video will describe seizures in epilepsy in detail.
More than 2 million people in the United States have been diagnosed with epilepsy or have experienced a seizure. During a seizure, the person has movements or feelings that he or she cannot control. The person may cry, fall unconscious, or twitch involuntarily. A person has epilepsy when he or she has seizures more than once because of a brain disorder. Sometimes people use the term seizure to indicate epilepsy. Epilepsy is one of the least understood diseases. This patient education module explains its symptoms, causes, and treatment options. It also covers what to do when a seizure occurs, how to live with seizures, and how to prevent seizures. What is a seizure? The brain is the control center of the body. The brain has 2 main parts, the right hemisphere and the left hemisphere. The right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. Directions about how to move and function go from the brain to the muscles and other body parts through the nerves. Certain areas of the brain control specific areas of the body. Some areas control vision, and other areas control other functions such as memory, movement, and sensation. Other areas are called silent because scientists have not identified their functions yet. Nerves are made of small cells called neurons. In order for the brain to feel, think, and give orders to muscles, the neurons fire electrical and chemical signals to each other. Seizures happen because of abnormal electrical activity in the brain. Depending on the area of the brain affected, a person having a seizure will experience different symptoms. For instance, if an area controlling a muscle is affected, the muscle may become still or jerk uncontrollably. A person may have only one seizure in their whole life. Epilepsy is when the patient has recurrent seizures due to an underlying disease of the brain. Causes. About 1/2 of all seizures have no known cause. The other 1/2 are linked to a disease or injury of the brain. During development and the first few years of childhood, the brain undergoes a lot of growth. During this growth, the brain is at danger of certain diseases due to infections, poor nutrition, and poor supply of oxygen. Some of these diseases are associated with epilepsy. The neurons of the brain develop into complex webs of wires. Defects in wiring during brain development could lead to epilepsy. After a head injury due to an accident or a stroke, the brain repairs itself by making new wiring. If the new wiring is abnormal, it could cause seizures. Disease of the brain, such as hydrocephalus and meningitis, could cause epilepsy. Poisoning of the brain, such as lead and carbon monoxide poisoning, could lead to seizures. Exposure to street drugs and overdoses of antidepressants could also lead to seizures. Older people sometimes develop diseases of the brain, such as brain tumors, strokes, infections, and bleeding. These types of diseases could lead to epilepsy. Some types of epilepsy tend to run in families, suggesting hereditary causes.
Dementia is the collective name for a group of disorders characterized by mental confusion, disorientation, memory problems, misperception, and sometimes behavioral problems. Each disorder has its own unique features, but the common factor amongst the dementias is that brain cells are dying quicker than normal. Before describing the various types of dementia, let's look at the brain. The brain is a fatty organ with the consistency of a jelly and is housed in a hard, bony casing called the skull. The brain contains millions of cells which are served by an enormous blood supply, which constantly provides oxygen and nutrients. Certain parts of the brain have specific responsibilities, such as problem solving, vision, and language. The types of difficulties experienced by someone will depend to a degree on which area of the brain has lost cells. However, it's important to note that there's not a direct link to the cells damaged and the behaviors we may see. For our purposes, we'll describe 4 large brain areas and the types of functions that cells in these areas are responsible for. It's also important to remember that the brain has 2 sides, the left and right hemispheres, and each of these controls different skills. The frontal lobe is located at the front of the brain and is associated with problem solving, personality, and motivation. It receives information from other areas of the brain and uses this information to make sensible decisions. Damage to the frontal lobe can lead to changes in personality, mood, and insight. It's the bit of the brain that tells us what's appropriate or inappropriate and stops us doing or saying things that aren't socially acceptable. The temporal lobe is located in the bottom section of the brain, at the level of the ears. It's important for interpreting sounds, language, and vision. The right and left sides have different functions, the left being more responsible for verbal skills and the right for visual. The hippocampus is also found here and is involved with memory. Damage to the temporal lobe can lead to problems with memory, speech, and language. The parietal lobe is located in the middle section of the brain and is associated with movement, spatial awareness, speech, visual perception, recognition, and processing tactile sensory information, such as pressure, touch, and pain. Damage to the left side is associated with problems with language and naming things, while damage to the right causes difficulties in making things, drawing things, and carrying out personal care activities. The occipital lobe is located at the back of the brain and is associated with vision. Damage to this part can cause visual problems such as difficulty recognizing objects, an inability to identify colors, and trouble recognizing words and detecting movement. Damage to this area can also produce visual hallucinations. Before moving to the next section, pause to take time to familiarize yourself with the brain and its functions.
The last section of this lecture will involve patients with disabilities. Within the United States, the U.S. Americans with Disabilities Act protect disabled individuals from discrimination. Those meeting the Disabilities Act definition are physically or mentally impaired with limitations to one or more major life activities. Patients with disabilities require special attention in daily life. This assistance may be permanent or temporary, and causes may be related to heredity, systemic diseases, trauma, or environmental conditions. Dysfunction leads to poor oral hygiene, rampant dental disease, and dental neglect. Prevention should focus on minimizing oral problems. This may require imagination, ingenuity, flexibility, and persistence to achieve a program that is best suited for the patient and their disability. Individualization and modification of usual procedures requires patience, calmness, and kindness on the part of the clinician, all of which are key elements in approaching special needs patients and helping them achieve oral health. Many disabilities exist in the classification of the disabled. Take a moment to view this list. You can refer to it when you are ready to select your patient conditions for your case study. Disabilities are categorized by levels of impairment. Within level 1, the individual function is near normal. Communication may be difficult and extra effort may be required for mental processing. Level 2 requires the stimulation of normal function with the administration of medication or equipment. Speech may be limited and the use of gesturing may be required to successfully understand the individual. This level may require assistance to access the dental chair, and medications are necessary for patients to maintain function. Level 3 requires a third-person party to conduct communication and function. The presence of a full-time caregiver is necessary. Level 4 individuals are unable to perform normal function. Home visits are required as these patients are typically immobile. The World Health Organization International Classification of Functioning, Disability, and Health is a universal classification of disability and health worldwide. This classification provides a standard of language for the description of health that is understood for the physical impaired. The emphasis on a person's disability is compared to the level of health. Approximately 1 in 5 persons are afflicted by a disability. Progressive mental care is increased survival, and rehabilitation trends has led to the institutionalization of these patients. Children with disabilities are being trained for community living as they receive vocational and educational counseling, medical and dental services, and work replacement to establish themselves as productive individuals. Specialized staff community housing is created for group living, and a variety of individuals cohabitate with impairments. Some have more than one type of disability, yet these homes are designed to provide as normal a life as possible for these patients. It is still the issues and barriers that do exist for these patients in acquiring dental care. Take a moment to watch this video on the lifestyle of a disabled person.
They seem like a regular family, doing what most families do. But these 5 people living in this house are not related. The 4 men have disabilities, and Amber Kimball is their living caretaker.
I don't look at it as work. It's just like their family, so I would do it for any of my, like my mom, I would do it for my dad. So I don't see it as being different.
But this house is different. It's a group home for people with developmental disabilities. The fact that it seems like a normal home means that Bella McCree, the company that runs it, is meeting its goal. The home incorporates the latest technology, such as the ceiling-mounted lift. Eric, one of the residents, says it's much easier than the old lift, which took 2 people.
That took a little bit more work because they had to pull me out of the chair, then lift me up a little bit, and then swing me around. They would always get my feet caught on the edge of the Hoyer lift. They get cut up.
It also makes things much easier for Amber. Even though she's 8 months pregnant, she can move Eric around on her own. This is only one of Bella McCree's 54 homes, all in the state of Maryland. Bella McCree means Home of My Heart in Gaelic. It's a non-profit organization with a $13 million yearly budget. Bella McCree's goal is to keep things as normal as possible. Stanley was born with a mild intellectual disability and has lived at different Bella McCree homes for 18 years. His brother Dwight visits often.
He's very independent, and when he was home with my father, he would help out with taking out the trash and getting the newspaper and getting the mail, and I think he still does it here. So it's works out real good.
In addition to the full-time staff, there are volunteers who help out, like Kyle Hines.
This is a great feeling when you're volunteering. You're giving that back to somebody, who might necessarily not be able to go out and do those things. So it makes you feel good inside.
And while making the residents' lives as normal as possible, the company also tries to help them be as active as possible in the community. CEO Robert Ireland.
Just that people with disabilities belong in the community, not away, not sheltered, but a real part of the community where they have the opportunity to engage in relationships, not only with each other, not only with staff, but with neighbors, with other members of the community.
Eric, for example, works at a local retail store.
I've been there 11 years at my job, and I make good money doing it.
Making good money gives Eric a sense of self-worth, and sharing that self-confidence with his housemates brings the Bella McCree family closer together. Tala Hadavi for VOA News, Arundel County, Maryland.
That was a good one. Patients suffering from physical impairment require motivation as well as their caregivers to maintain healthy oral tissue. The appointments must be pleasant and comfortable, and additional time may be needed, as well as special equipment, pre-medication, and addressing transportation issues. Pre-treatment planning may require authorization from the patient, the guardian, and the physician. Consultations with the physician must be ongoing, and additional time may be required to fulfill the treatment plan. Provide a list of special aids that the patient may need and have it readily available as transfer boards or chair supports. Wheelchair accessibility guidelines have become a national standard for public spaces. Barrier-free environments with passages up to 3 feet wide and areas free from obstructions constitute some of the guidelines. Level floors and non-slip surfaces and reception chairs 18 inches high, flat, firm seats with arm for supports are required in all dental offices. Reserved parking areas must be 13 feet wide with an entrance that is easily grasped by handrails. Lightweight doors with a lever type of a handle for opening must be available. If a wheelchair is used during treatment, they must be designed to recline for patient access. Teaching areas for home care and biofilm control require a tabletop and a wash basin that is 32 to 34 inches from chair clearance. Mirrors, sinks, and faucet handles must be handicap accessible and lever type for use. Transfer techniques for dental appointments should be assessed to determine which transfer procedure is appropriate. The patient's size, weight, and mobility play a key role in how the transfer should be done. Patients may favor one side for transferring, and the removal of all obstacles and the remembering of engaging the wheelchair brakes should be done prior to the transfer. The stand and pivot technique is illustrated above. This procedure is done for patients that cannot support their own weight. The wheelchair faces the same direction as the dental chair at a 30-degree angle. Set the brakes and remove the footrest and armrest. The clinician places their knees next to the patient to prevent any buckling and to place their arms underneath the patient's arms at the waist. The patient grabs the clinician's neck and the clinician pivots the patient into the dental chair. Patients who cannot support their own weight will require a second person to assist them. A sliding board can also be used in this procedure. Let's watch the following video as the use of the sliding board is demonstrated.
Ask the patient to scoot to the edge of the seat. The patient shifts their weight away from the patient chair and the edge of the board is placed under one buttock and laid across the dental chair. The patient should reach for the opposite side of the board while sliding across the board. A patient with insufficient upper body strength may be assisted by a team member lifting up on the gait belt to guide them across the sliding board.
While assisting patients with walkers, crutches, or canes, the following instructions should be adhered to. When using walkers, adjust the dental chair upright. Have the patient back up into the dental chair. Allow the clinician to stabilize the walker. The clinician then takes the patient by their ankles to lift their legs. The clinician then turns the patient onto the chair and the walker is removed. When using crutches, the dental chair is positioned upright at the patient's knees. The clinician assists while the patient lowers into the chair. The patient's legs are lifted onto the dental chair. And when a patient is using a cane, the dental chair is positioned at the patient's knees or higher. The patient may need assistance in lifting their legs onto the chair. In dealing with patients with physical impairment, we must be aware of how we approach reclining them in our chair and to tip this chair back very slowly. The chair cannot be reclined with patients with severe respiratory issues. The use of pillows for comfort may be needed, and always allow your patient to adjust themselves with proper circulation. Minimal restraints to prevent injury may require consent prior to use. We have what we call the pedi wrap. It is made of a nylon mesh and encloses the patient from the neck to the ankles. A papoose board with padded wraps enclose the patient for sustained stillness and head stability. Only under certain conditions that these pieces of equipment are going to be used on our patients.
Blindness may be a secondary condition to a primary cause. Legally blind is a legal term, not medical term, and those with partial vision loss may be classified as legally blind. Central vision, or also known as acuity, is vision that is not more than 20/200 with corrective glasses. Peripheral field vision, also known as side vision, is vision that is no more than 20 degrees in diameter or 10 degrees in radius within the viewing field. Only approximately 3% of legally blind individuals are actually totally blind. Age is a leading cause of blindness. The condition is also caused by diseases as diabetes, which is called diabetic retinopathy, age-related macular degeneration, senile cataracts, glaucoma, vascular disease, eye trauma, and infections can lead to blindness. Children who are blind is typically of prenatal origin resulting from maternal infections as rubella, syphilis, toxoplasmosis, injuries, neoplasms, and retinopathy of prematurity, formerly called retrolental fibroplasia. When assisting or working with someone who is visually impaired, offer to provide assistance as escorting the patient to the operatory or for completion of the medical history forms. Ensure you have cleared the path to the operatory, and provide forewarning of any obstacles that may cause the patient any difficulty in accessing the room. Patients may prefer their own protective eyewear instead of the goggles provided by the office. Do not distract the accompanied guide dogs, and ask permission to pet and acknowledge them. Confer with the patient as to where would be the best place for the guide dog to rest. For proper documentation, you should record the patient's limitations and chart. Visually impaired children may appear to have learning disabilities. Allow them to become familiar with their surroundings before engaging in the procedures scheduled for the appointment. Patients are sensitive to tone of voices, therefore, provide clear instructions for clinical procedures. For some patient, tilting of the operator chair for positioning may cause some patients increased eye pain. Confirm with the patient that their seating position is comfortable for the length of the appointment. The overhead light or operatory light may cause sensitivity to the patient when reclined. Be aware of positioning for patient's best comfort. Glaucoma patients have limited to no peripheral vision. Instruction should be given from in front of the patient, and limit attention to fine details. Take a moment to view these images. They illustrate the seeing ability of patients living with these conditions. The following videos will explore these conditions for a better understanding of how they affect patients and their quality of life.
The most significant symptom of macular degeneration is blurred or distorted central vision. Over time, macular degeneration can affect vision by forming a blurred, darkened, or empty area in the center of vision, or distorting one's surroundings, most noticeably in the appearance of straight lines. Macular degeneration may also cause colors to become less vivid. Blurred or distorted central vision can cause an inability to perform tasks that require precision, like driving a car. Fortunately, this disease does not cause total blindness because side vision is not affected. If macular degeneration occurs in only one eye, the symptoms of the disease may not be noticed right away, as the good eye compensates for the bad eye. It is essential to take these symptoms seriously and to speak with an eye care professional immediately if they are developed.
Diabetic retinopathy, a sequelae of diabetes, known to cause vision impairment or complete blindness, is treatable. Though treatment modalities are available, the asymptomatic onset and sudden progression can catch the patient unaware. The best option to prevent the disease is regular and frequent eye examinations. However, even after onset, the disease can be blocked or progression delayed by access to appropriate therapy.
A cataract is a clouding of the lens in your eye that affects vision. Most cataracts are related to aging. To understand how a cataract can affect your vision, it helps to understand a little about the structure of your eye. The lens is clear and lies between the iris and the pupil. It works much like a camera lens, focusing light or an image on the retina. The retina is the light-sensitive tissue at the back of the eye. Once the light or image reaches the retina, it is changed into nerve signals that are sent to the brain. Besides focusing light on the retina, the lens also adjusts the eye's focus, letting us see things clearly both up close and far away. The lens must be clear for the retina to receive a sharp image. The lens is made of mostly water and protein. The protein is arranged in a precise way that allows light to pass through it without distortion. But as we age, proteins in the lens clump together, causing a cataract. At first, the protein may clump together and cloud in a small area of the lens. Over time, the clumps may increase in size and number, clouding more of the lens. If the lens is cloudy from a cataract, the image you see will be blurred and colors may appear faded. A clear fluid flows through the anterior segment at the front of the eye, nourishing tissues. At the open angle where the cornea and iris meet, the fluid flows through a spongy meshwork and leaves the eye. But if it passes through too slowly, pressure inside the eye rises to a level that damages the optic nerve, resulting in vision loss due to open-angle glaucoma. Untreated, the vision loss progresses from normal vision and no pain to gradual loss of peripheral or side vision and eventually total vision loss.
嘢嚟咗啊？
係啊，我嚟咗煲咗啲粥俾你。
啲粥好味啊！
Deafness refers to those unable to interact by spoken communication. Hard of hearing refers to those with defective but functional hearing ability. The causes of hearing impairment can originate from the outer, middle, and inner ear, or a combination of more than one area. Contributing factors for deafness include heredity, prenatal infection in the mother as rubella, trauma from birth, chronic inner ear infections, infectious diseases as meningitis, and toxic effects of drugs. There are several types of hearing loss. Conductive hearing loss originates in the outer or middle ear of the conduction pathways, the inner ear. Sensorineural hearing loss is damaged the sensory hair cells of the inner ear, or nerves that supply sensation to the inner ear. Mixed hearing loss is a combination of conductive and sensorineural. Central hearing loss is damage of the nerves or nuclei of the central nervous system in the brain or pathways to the brain. The following video illustrates the physiology of hearing loss.
During normal hearing, sound waves travel through the ear canal and strike the eardrum, causing it to vibrate. The eardrum is attached to 3 tiny bones in the middle ear. The last bone, the stapes, pushes on a fluid-filled chamber in the inner ear called the cochlea. This fluid movement causes sensitive hair cells within the cochlea to bend. When the hair cells bend, they generate an electrical signal that is sent to the brain. Age, disease, injury, or repeated exposure to loud noise can damage the various structures of the ear and interfere with hearing. There are 2 specific types of hearing loss: conductive hearing loss, which is caused by a mechanical problem in the ear canal or middle ear that blocks the conduction of sound, or sensorineural hearing loss, which is caused by damage to the inner ear, auditory nerve, or auditory nerve pathways in the brain. Conductive hearing loss is often reversible. Sensorineural hearing loss is not.
I think you will enjoy this video on the experience of hearing loss.
See the USA in your Chevrolet. America's asking you to come. Drive your Chevrolet through the USA. America's the greatest land of all. On a highway or a road along a levee. Performance is sweeter, nothing can beat her. Life is completer in a Chevy. So make a date today to see the USA. See it in your Chevrolet.
Traveling east, traveling west, wherever you go, Chevy service is best. Southward or north, near place or far, there's a Chevrolet dealer for your Chevrolet car.
See the USA in your Chevrolet. The Rockies way out west are calling you. Drive your Chevrolet through
Hearing aids are extremely expensive. These electronic devices amplify and shape sound waves that enter into the external auditory canal. In the inner ear models, units are particularly invisible or lightweight. The canal aids models fit entirely within the canal and hardly are visible. Also, there are ocular implants that are small electronic devices that are surgically implanted, and they provide a sense of sound to a child or adult who is profoundly deaf or severely hard of hearing. Implants consist of an external portion behind the ear and a second part that's sometimes surgically placed underneath the skin. These implants do not restore normal hearing. However, they allow them to be more sensitive to sound waves. One thing we need to remember is to advise our patients to turn down their hearing aid volumes because of the sound equipment in our room can be very uncomfortable for them. Also, the other thing is to be very careful not to allow any water to drip into the ear canal or into the ear area when you're rinsing a patient or cavatroning, because these pieces of equipment are, like I say, extremely expensive and run into the thousands.
You may want to remind patient with hearing aids to turn them off or lower them while performing the cleaning. Ultrasonic equipment, power-driven handpieces and suctions create frequencies that are often magnified by the hearing aid. When working with patients who have partial hearing ability, it is best to speak clearly and distinctly and face the patient when speaking. Take care to eliminate noises from suction or other pieces of equipment near or in the operatory. Speech reader will require you to face them, as your entire face must be clearly visible. Speak in normal tone and do not exaggerate words. Your pace of speech should be slow and pause more frequently than usual. Do not raise your voice, as this can distort lip movements and make lip reading more difficult for the patient. Sign language and the use clipboard for written messages is always a great alternative to improve communication. Manual communication with patients who have hearing loss may involve the use of sign language, writing, and oral communication. Signing with American Sign Language uses visual gestures that includes grammar and syntax in the delivery of speech. Finger spelling or spelling in the air is another means of easy communication with patients. Oral communication is a combination of speech, residual hearing, and speech reading. Speech reading consists of recognizing spoken words by watching lips, face, and gestures. Mouth movements for spoken words do have similar appearance as one or more other words, and this can cause confusion for patients. Speech reading combined with another method of communication is best, as speech reading is not reliable. You may consider writing as an alternative. Disease prevention is the goal in any patient planning. Education to reduce biofilm, improve caries prevention through fluoride applications, sealants, and diet, as well as smoke cessation when necessary, and regular professional examinations and treatment are at the heart of our practice. Cooperation and failure to comply can best be addressed through education. Lack of knowledge, motivation, and physical impairment can be addressed and improved upon with the correct tools. Education is the primary means for disease prevention and control. The following are treatment options in patient care: dental biofilm control, fluorides, pit and fissure sealants, diet counseling, smoking cessation, regular professional examinations and treatment by the dentist and dental hygienist. Cooperation and failure to comply can occur from a lack of knowledge and understanding, a lack of motivation, or a lack of the necessary mental or physical coordination required to perform the tasks. The following are basis biofilm removal aids. Toothbrushes recommended for patients with limited dexterity can include electric, reinforced handles, and specially designed to meet their needs. Dentifrice containing fluoride should always be recommended. Interdental cleaners as floss aids, stymidants, perioaids, water packs, and interdental brushes should be considered when designing the patient's oral hygiene regime.
One of the big problems with handicapped patients is being able to stabilize their dentures when they're using them to clean with. So creating some type of stabilizing equipment will actually help them. They have grasp problems or some only have one hand. So protecting their partial dentures by covering the basin with a washcloth or small towel is really important when helping them clean their dentures. The other thing is, as you're working on them, you may also have issues with stabilizing your equipment. So the use of bite blocks or tongue depressors may be important while you're in there doing your clinical procedures. These following slides are use of oral hygiene aids. The next 3 slides are on different charts that you can reference in designing the home care regimens for your patients. One of the major problems on your boards is selecting the appropriate oral hygiene aids for specific patients. So take a moment, study these charts, and keep them as a reference later on as you study for your boards, because it is an area that students typically score poorly on.